Before we close, I want to get a perspective on the ALK-positive patient. I'm going to ask MJ. In my practice, alectinib is the standard of care in a newly diagnosed ALK patient. You agree or disagree?
Well, if you go by, I agree. The short answer is I agree. And a little longer answer is that NCCN guidelines have put in now 4 options in the first line and even left crizotinib in those options, which may appear odd in the United States. Why would you leave the losing arm? And it wasn't a close loss by wide margin as an option. But I think NCCN views itself as a global organization, and not every country has anything other than crizotinib available. But I think that brigatinib is proving to be a bigger player. We need to wait for maturity of the data to some degree. But if all other things are equal, whenever things are equal, small things become important. I usually say when both cars are Tesla, color is important. So if all other things are equal, taking 4 pills twice a day versus 1 pill once a day can make that difference.
Convenience,
yes.
benefit, yeah.
Yes.
Others agree? Alectinib for the most part?
Yeah, I mean, the alectinib data is really fantastic, a huge gain for patients. You know, the brigatinib data, you know, what we've seen from the ALTA first-line study, at least the data that's been presented so far, the PFS for alectinib versus crizotinib was 0.47. For brigatinib, it's 0.49. So those are 2 very similar values. So I agree with MJ's point that small things may make a difference, but the good news is we've got really good drugs now for first-line.
A lot of drugs for a small percentage of,
right.
of that population.
Right.
Leora, we talked a lot about EGFR resistance and that sort of thing. What's your take on the ALK population in terms of pattern of resistance? Should we be retesting? What should we be looking for? All those sorts of things.
So I think we should be retesting. You know, we do have lorlatinib now, and if retesting is just not an option and you can't biopsy, it is the one drug that we know targets G1202R well, and G1202R is the most predominant mechanism that we're seeing of resistance to alectinib as well as brigatinib, and it has been up to now the most difficult one to target. I think that if a patient can get a biopsy, be it liquid or tissue, that would be the preferred thing to do, and we can figure out what their mechanism of resistance is, and based on that target the next drug. But we have lots of different agents to choose from. Luckily, those patients are on therapy, so having them hurry up and wait is not as bad. And NCCN has included lorlatinib as a potential option in that space of patients who progressed on a second-generation TKI.